So for my schedule now, I have plenty of built-in virtual visits. There are patients, surprisingly, who still don't want to come in. So it still gives an opportunity for those patients that whether they're brand new patients or whether they're post-op patients or MRI reviews, which I found to be my favorite, is imaging reviews for telemedicine.
Welcome to the Growing a Successful Orthopedic Practice podcast. Join us every episode to hear from fellow medical practice administrators, staff, and physicians as we break down current issues affecting the industry and share real stories from guests on their way to growing a successful orthopedic practice. Let's get started.
Hey there, welcome to our new podcast, Growing a Successful Orthopedic Practice. I'm Jennifer, and I'm going to be your host. Join me bi-weekly for can't-miss interviews, insights, tips, and tactics from orthopedic leaders around the U.S. On every new episode, you're going to hear directly from physicians, medical practice administrators, and industry partners as we break down current issues affecting our industry and share real stories from guests on their way to growing a successful orthopedic practice. Now, topics are geared specifically for ortho practice administrators and surgeons and include strategies for reimbursement, marketing, employee engagement, technology, HR, budgeting, and just about everything in between. So a little about me and the team that's putting this show on. My name is Jennifer, as I said, and I own and operate Insight Marketing Group and have done so since 2006. So what the heck am I doing hosting this show? Well, our offices are inside of a very large orthopedic practice. In fact, our marketing suite is literally attached to their ambulatory surgery center, which is right next door. And we work with a ton of orthopedic practices and surgeons. The idea for this show came from one of our clients, but they didn't have time or resources to put it together, so I volunteered us. Now, we're not new to podcasting. In fact, we produce a weekly show, the Dr. Marketing Tips podcast, and that show just celebrated its 240th episode. So I certainly urge you to go check it out. That's the Dr. Marketing Tips podcast. So in this very first episode of the Growing a Successful Orthopedic Practice podcast, we're going to join into a discussion between two surgeons and a practice administrator about the orthopedic practice of the future. And there's a lot of really good talk about telemedicine and how surgeons are using it. Today's discussion is led by James Coyle and Stephen Kalazzi of Ortho Live. Ortho Live is the sponsors of this show. And they're going to be joined by Jeffrey Cave, the Chief Operating Officer of Orthopedic Associates of Muskegon, Dr. Adam Metzler, an orthopedic surgeon from Ortho Cincy, and Dr. Gil Tepper, an orthopedic spine surgeon from Valley Spine Center in Los Angeles. Be sure to stay tuned because in this episode, you're going to learn how practices are recovering from COVID-19 closures, ways to allocate resources to attract and retain your employees, what can be done to reduce patient leakage, when and how clinical roles will continue to evolve, and what technology has done and continues to do to impact the patient experience. I really hope you enjoyed the show. Be sure to hit the subscribe button on your podcast player so you don't miss a future episode. Let's go ahead and get started.
What has the initial impact of COVID been to the practices that you've helped with?
That's a really good review of for the mindset that we're all in, both as practitioners, as patients, administrators. I personally have started exploring telemedicine late last year, early this year, because I was preparing for semi-retirement and I wanted to shift into a different method of delivering care. Obviously, as soon as COVID hit, the biggest thing is as a novel virus, we were all stung by something on a global scale that we've not seen before. And, it basically stunned a lot of systems, certainly most importantly, self-protection and emergency care. And the trickiest thing about it is that there's more unknown than known about it, and the data is shifting a lot. But The practices had a profound impact immediately. Elective surgery was stopped. It was recently resumed, but it's slower, and there's some places, including California, where it may be stopped again. I think a lot of us, either before or during this transition, luckily we've had some time off to expand, to think, and to try to procure a system to continue interaction with our patients and to carry on with the care. And a lot of us have jumped on whatever was available in the very, very beginning. Many systems that were not necessarily HIPAA compliant, that had challenges with security, had challenges with delivery, and had very limited integration and functionality beyond the video conferencing. So it was just a fancy phone call, but if you had to get some stuff done, it became time consuming and cumbersome. And right now, things are loosening up a little bit. I think that people that have jumped on systems with poor fit or poor functionality are in the market looking for better systems, better integration, and more specialty integration and functionality. And I think personally that these are all good things because for many, many years, I'm probably guilty of it also. I mean, I thought the whole world and my practice and my patients all revolve around me, but I had to remind myself that my practice has to be a patient advocacy practice. It has to be patient-centric. It has to integrate the family and complex decision-making, lifestyle changes, et cetera. And I think that telemedicine as a platform on a going forward basis really lends itself, for me as a clinician, to deliver a much, much better, much more customized, much more efficient, patient-centric care.
Thanks, Dr. Tepper. Dr. Metzler, are you with us?
Yeah, thanks for being patient. I had some updating issues with Zoom, so
No
sorry
worries.
I'm coming a little late here.
No problem. I already introduced you because I knew you were on your way.
Yeah, no worries.
Same question to you. How has COVID-19 affected your practice?
Well, I was just catching probably the last half of what Dr. Tepper said, but a lot of what he said is definitely what I agree with. I mean, Dr. Tepper, where are you practicing?
I'm practicing in Los Angeles, as I have been since I've finished fellowship.
Yeah, so I've been in Cincinnati at Ortho Cincy now with 8 years now, and I'm a sports medicine specialist, knee and shoulder arthroscopist. And Mark Twain said, if you want to live 10 years longer, come to Cincinnati when the world ends. So I would say things are probably drastically different in Cincinnati than they are in Los Angeles. However, I think the region was pretty strict very early on, and that sort of set the tone for a lot of what we did within medicine. So Ohio and Kentucky made pretty strict guidelines pretty quick with COVID. And I think it definitely helped, spur some of the early cases. I think we're all under fire now with this resurge, if you will. And so right away, we stopped elective surgeries mid-March. And as a sports guy, that was pretty devastating to my practice. Thankfully, I still have a large call pool that I'm a part of, and still did a lot of cold trauma. So there was enough to keep food on the table for the family. But it was a drastically different scenario from going from 150 ACL surgeries last year in 2019 to I'll be lucky if I hit 50 this year with no sports. And I think the thing that immediately came to mind for us was we already had somebody who was working on something good, which was Dr. Greiwe with OrthoLive. And I think, to be honest, we were very hesitant to utilize telemedicine in our market. Cincinnati is a very conservative market. It's not progressive, having grown up in this town as well. The concept of telemedicine, particularly in orthopedics, is really a progressive idea. And the pandemic certainly pushed that to the forefront. So progressing everything in every way we think. And I can be honest, I mean, Dr. Greiwe has pushed this agenda to me many times, and I've not been accepting as I should have been, primarily because my practice was so well oiled without having to deal with telemedicine. We would see my physician assistant and I 70, 80 patients a typical day. So why do I need to integrate telemedicine in when it's already well-oiled machine? And well, that's what COVID-19 did. It messed it all up for everybody. So we all have to figure out ways to adapt. and adapt and survive like anything else. And we've done that. And no matter what platform you're on with telemedicine, I think you've had to survive and adapt. I personally was able to accomplish close to, I think, to 250 telemedicine visits during about a 10-week period. Those are 200 patients that needed some type of patient contact. I didn't have one single complaint, which I was very surprised with. I figured patients would be very apprehensive in our market to do that at all. They weren't. They were very happy to be at home. Is it different? Was it an adjustment? Absolutely. Your templated exams, all these things we've been doing for years, that has to change. You can't template a physical exam that's normal when you've never touched a knee before. So those things had to, adapt. You had to be very adaptive for that as well. But I still find now that we have adjusted our schedules. We are on our pandemic schedule number 4. Pandemic schedule 5 would be a normal template for us. In order for us to stay socially distanced, we have adjusted our templates so that the physicians can see a set number of patients for each half day of clinic, in addition to our extenders, a set number of patients, as well as the regular PP adjustments that every practice has made. I don't know if we'll be back to full schedule, essentially unrestricted schedules, probably until, I can't imagine until 2021 within our large practice of 32 physicians. There's just too much chaos within the waiting room to create normal unrestricted schedule. So for my schedule now, I have plenty of built-in virtual visits. There are patients, surprisingly, who still don't want to come in, or not surprising, I should say. And so it still gives an opportunity for those patients that, whether they're brand new patients or whether they're post-op patients or MRI reviews, which I found to be my favorite, is imaging reviews for telemedicine. That now that it's forced to be adaptable myself and adjust my schedules and schedule to adjust for what the patient's needs are, just like you said. And there are more patients asking and requesting for telemedicine than I ever would have expected. So I think that's the biggest adjustment for us. Obviously, the practice management things are different. We see less patients. We're more cautious. We're more careful. We clean more. We don't let people sit in the waiting room. We have patients wait in cars. If the waiting room gets too full, we have waiting room monitors to make sure that that's not happening. So I feel blessed to be part of a big practice with good rules and good regulations, and affiliate with hospitals that helped us to get those set up. But I think, to echo you, that's where we're at.
Perfect. Jeff, so from the business side of things, how has the practice changed through COVID-19?
Sure. So, and thanks for that introduction, Stephen. So, Orthopedic Associates of Muskegon, we've got 19 physicians. As of next month, we have 11 mid-levels, and they are spread out across 3 different physical practice locations. We also have an urgent care that is staffed by primary care sports medicine physicians at one of our locations. So COVID in Michigan came pretty fast and furious. We were actually one of the later states to get our first case, but after that first case happened in Michigan, we just ballooned off. We're under executive orders to only see urgent and emergent patients for about 8 weeks. So starting late March through late May, we had a total practice shock, if you will. We closed 2 of our locations just to consolidate staff. We actually relocated our urgent care from one location to our main larger location. On the business side, unfortunately, we had to lay off a great number of our staff. The positive, though, which it's crazy to think that we're already beyond this, is that they've all returned to work as of late May, when we were able to see more than just urgent and emergent patients. So while that was very difficult in the moment, now that we're on the other side of it, that we're glad that everyone is able to return. And through that, we implemented OrthoLive was our telemedicine platform we decided to go with. And the COVID-19 really was that push. So I haven't been with OAM for too long yet, but I knew that implementing telemedicine was on the roadmap, but where on the roadmap is undefined. And so had we not had COVID-19, we likely would not have even touched telemedicine yet. So knowing that we needed to spread out the patients, knowing that patients didn't want to come into the practice either for a while there, and some still don't, we needed to provide some type of solution for them. So implementing OrthoLive was definitely a huge help and a big kind of nugget of hope that came through with the pandemic. But there were also some other positives too, that we were able to send more staff to work from home that we may have not explored before. So when we kind of started under these stay home, stay safe orders by our governor, I think there was a little bit of panic and fear across the state and the community, and people really just wanted to be home. And so it did get some of our administrative staff kind of scratching their head going, I think I can do my job from home. And through that, we now have more ways to track productivity for some of the staff we deployed to their homes, because we said, well, you can't just go home, and we have to have a way to track you. And then that kind of geared up some of the staff that didn't necessarily have a metric or measurement for their role to say, well, this is what I think, and then we can come to an agreement. And then we let those staff go work from home now. Since then, some have returned, some have flourished at home, prefer to stay at home, and we can now track them. So that's another kind of, along with telemedicine, nugget of, hey, this actually worked out well, and chances are it would have taken us 6 months to a year to figure it out if we weren't in the middle of a pandemic. Physician schedules were all over the place. We, if we're only seeing urgent, emergent, each surgeon really went down to about a day a week, some a half day a week in the practice actually seeing patients. As everyone in the country or the world, we really started utilizing Zoom and other technologies for even our administrative meetings. And of course, I'm sure everyone's done this, removing a great number of chairs from the waiting room, social distancing stickers on the floors. We have plastic kind of shield dividers at a lot of the desks. So when staff or patients have a surgery schedule they need to have, or a workup, when they are meeting with staff at a desk area, they have a shield there between them. So every day was a totally different day. At the beginning, when we saw this happening and we unfortunately laid off a lot of the staff, we thought, well, we might have some time to get a lot of stuff done that we haven't gotten done, like policies and procedures, and really roll our sleeves up. But that wasn't the case. It just came every day with new executive orders and new PPE loans you could potentially apply for, and how we're getting back to normal. Every day was just a little crazy, but in a good way.
Perfect. Thank you.
It's interesting, Jeff. It almost seems as though you it gave you a pause to, this. I think Becker's quoted something like 65% reduction in patient visits during that March through April period. So it almost gave us many of the practices a pause to think about, all right, how are we going to adjust to this?
Yeah, we definitely saw that, if not more. We did see a slight uptick in our urgent care, which I think was a little expected, because a lot of our local urgent care is closed and a lot of our local primary care offices closed as well. And so with our urgent care remaining open, we actually had a little relief there. I mean, nothing compared to elective surgeries, but it was interesting to see that take place.
Right. Well, with that, you guys have actually moved us right into our second question partially. So we'll go to the next question. It's, how is it currently today? You've talked about how COVID impacted you and how you've adjusted. So where do you see yourselves now as things are are they getting back to normal, or are they never going to be quite normal? What's the picture look like today?
I'll jump in. So I think there's a new normal. So I don't know that we'll ever be back to a normal. Similar to the physicians on here, we are limiting the amount of patients that can come through our door a day. So we are not on a total unrestricted schedule. The physicians are still not seeing as many patients as they would prior to COVID, but we are up there in a way. We are extending hours for physicians that have somewhat of a backlog. So prior, if we would maybe see patients at 8 and the last patient at 4:30, we now are starting at 7 and can go see patients at 5 or 6. We've been open every Saturday in June. We're open this Saturday, just exploring different ways that we can get the patients in the door. Telemedicine is a huge part of that, because we're doing this for really social distancing. So if physicians have the capacity and want to see more patients, we're not going to hold them to a number. We'll hold them to around a number of physical patients, but they can add on as many telemedicine patients as they want, which is great. And we have some that are really embracing that. Like I mentioned, that we're fortunate everyone returned to work. There is this interesting almost phenomenon of staff. We aren't even up to our full capacity yet, but when staff are not working for 2 months and they come back, it kind of takes a while to get back into that group. So we're kind of going through that of, how did we ever see, 90 patients for some physicians months ago, and now it feels like we're burning out, going around 50 to 60. So that's been interesting to go through. And honestly, from an administrator standpoint, one real struggle we have right now that we deal with almost on a daily basis is when staff have exposure to COVID in their personal lives, or they have someone in their household that has symptoms, and who can come to work and who can't come to work. And there was a COVID, if there was a COVID positive patient in that we found out after the fact, and who interacted with those patients. So really, when I say we're not back to a new normal, we're going to a new normal is because we're managing COVID still every day with a fully busy practice. And that's just been the greatest headache, is coming in and getting 5 text messages of, hey, I was with a friend last night, now they have symptoms, or my spouse is getting tested, and just going, okay, we look at the CDC guidelines, try to follow those as much as we can of who can and can't come to work safely, and still manage staffing has been challenging.
You don't even think of the human resource aspect, but now that you mention it, the idea of staff and what can you do when if they get COVID, they certainly can't come to work.
Right.
And then all of a sudden you're really stuck. Just curious, when you go back to like at the beginning, what percentage of the patients were virtual versus inpatient, and where do you think your percentage is today?
Prior to COVID or during our kind of 2 months there?
During the heat of COVID, and then where you think you are now?
So during the heat of COVID, our telemedicine population was probably still maybe 25% of our patients. It definitely could have been higher, but it was brand new to our practice. So we had some physicians that embraced it fully, and we had some that are still, everyone does them now, but we still have some that would prefer to have their patients come in. So overall as a group, I'd say we were probably around 25%. Now we are actually still a little bit lower than that as we're learning how to get telemedicine plugged into our new normal. We know that it's something we have now, we want to utilize it, and we need to utilize it going forward. But now that we're finally in this, okay, how many patients make sense to come into the building? So it's still a day-to-day discussion of what makes the most sense. I have some physicians who do see a great deal of telemedicine patients, and I have some that don't see near as many. So it's kind of all over the board. We leave it really provider specific.
Interesting. Gil, Dr. Metzler, anything on that?
I think that we're still in a transition period, and I think that some of the practices are optimizing the system they procured. I think Jeff did well and got into a good system early on, so there's minor adjustments. But there are people that jumped into systems that have presented significant challenges that required pivoting. And so we're in a transition period where each specialty, orthopedic being one, other specialties, is going to settle into a mixture of visits. Again, I think in a patient-centric way for the visits that don't absolutely require an in-person visit. And then there's going to be the clinician way when a more complex exam or situation comes up where the person should be seen in a face-to-face and examined more thoroughly, or decisions are more complex and should be done face-to-face. But it's going to take a little bit of time to figure out where this whole thing is settled. What I like about this transition period is that we get to examine efficiencies, flexibility of schedule. I can tell you when I got started, this is for Adam, when I got started practicing, one of the guys in the group had late night hours. I mean, late, like 10, 11, 12 at night. And his patients kind of liked it. He had a group of patients that either liked it because that's what he wanted to do, but he would see him in the clinic late and so on. And it always seemed odd to me. But today, it's all about customer service, patient efficiencies. Patients love doing the important things they need to do on their own schedules, their own terms. Hey, let's not forget, we're challenged as an industry, we're challenged as individuals, and all of our patients also have incredible family challenges, kids, schools, virtual schools, entertaining these kids. They need flexibility also, but we don't want them to neglect their health and not deal with what needs to be dealt with. So telemedicine, flexible scheduling, asynchronous messaging, like uploading all the stuff until it's all ready and then having that meeting. I think that helps the patients, and I think adoption will increase. I think it helps the clinicians as we get more and more proficient with it. I mean, I'm 60. For me, the challenges are also technological adoptions. I'm not at the cutting edge of anything. I'm trying to learn and adopt. So I represent those of us, that have not been growing up with tremendous degree of technology. And it's a challenge, but it's fun. It's a period of a lot of creativity and generativity. And if we're open to adoption, then I think we're going to wind up in a great place through telemedicine.
Yeah, Yeah, my take on this too is obviously similar as well, but I'm in a unique position of being on our board as well right now. So I'm a little bit younger than you, Doc. I'm 40, so you got 20 years on me there. But being on the board and during this process has been unique. We met every 3 days for 10 weeks. So we made huge adjustments in very short periods of time. We spanned down to just being able to see 15 total patients per half day per physician, including the extenders. That was it. That was all we could do. That's all we knew how to do. And that's, I think, what a lot of practices did. Urgent and emergent only, made those decisions. And then so that was sort of our pandemic schedule 1. And then we evolved over to the current template, which allows us to see up to about 20 to 25 patients in a half day with unlimited telemedicine. So I'm pushing the telemedicine for my own practice because it allows me to add additional patients. Particularly my MRI is my favorite way to do that. And that's just a great resource. It doesn't always work out well if they needed an injection, but anything I think potentially could be surgical, it's a great way to do it. You can share your screen. You can, the patients love seeing that. When you can share everything that you would show, you're going to show them all the things, all the resources that I developed during my downtime, sitting on my front porch, not operating, was I created a whole subset of pictures and PowerPoints, and I could boom, pop it right up, and rotator cuff tears, and what does it look like? What's an ACL look like? And little videos and clips and things that I can show them while we're on the conversation. I think, I adapted, and my patients love that component of it. They have no questions going into surgery. I still challenged with the fact that we don't limit or let family members come into the office, and for obviously everyone's safety. But I get a lot of questions today of, well, you never discuss this with my wife. Well, now put them on speakerphone. We used to never do that. They need to be a part of this conversation. As I talk, they need to hear a part of it. We used to limit video and audio recordings, all that stuff in the room. We still don't want them to record. Obviously, those things could be dubbed and changed to whatever patients want to change it to, and that's very easy to do. But at least at least with FaceTime and with just speakerphone, the families are there with them. Obviously, if the patient has dementia or something like that, or a young child, they're going to have a secondary family member. But those are certainly some adjustments that patients have made. And in general, patients understand it's a trying time, and we're all working through it together. Very few patient complaints during the pandemic and after the pandemic, and I think patients actually get it. That we're all working hard. We're all trying to make adjustments. We're all learning on the fly. I think if you don't, then their patients have every right to be nervous and afraid and upset. But I think most practices that are going to be successful are going to adopt significant rule changes, adopt telemedicine, and listen to their patients. And those are the things that we have done amongst the many other things, adjusting hours. We cut back our urgent care clinic pretty quickly, but we do have an urgent care. It's been very successful for over 10 years. We have Saturday hours, which patients love. We still don't have close to the volume for our urgent care that we typically have had, but we're getting back to those numbers. From a future standpoint, I think it's, here even in Kentucky and Ohio, we don't really see high school sports happening. We don't think it's going to happen, even though everyone keeps talking about it. Some of the kids are practicing in Ohio, but in Kentucky, they barely are conditioning right now. And with the surge, obviously, everywhere going on, I just don't see it happening. So for me, it's a change in practice. I'm seeing more arthritic patients and rotator cuff issues than I am young ACL and patellofemoral issues. And that's just an adjustment. I still can't believe that I'm fairly busy. I'm still filling 45 to 50 slots a day, in-person visits, which is crazy to me. And crazy in the fact that I didn't think that would happen. And I probably fit another 5 to 7 virtuals in during the day. That typically would have been a 60-person day template with another 20 plus for my physician assistant easily. So, we're all probably taking a 20% hit, but it's the new norm for now. I do think through 2021, we're probably going to feel the same pain. I think it's going to be 2022 for those numbers, if not 2023, before my 2019 numbers return to what they were financially. So I expect 2 years before, quote, herd immunity and an effective vaccines are out there for patients and politicians and attorneys to feel comfortable to allow us all to open up and do what we did before.
Let me ask you a question about, you talked about telemedicine. Are there other technological advances that you've looked into? And if you have, how do you make the decision which ones to go with in practice?
It's forced us to look at our EMR and our practice management system at the board level, and we are going to be making some pretty drastic changes to those allow us to be more efficient, particularly allowing people to work from home with the system. The current platform we have that requires a lot of in-house intranet versus internet type of work. It's a little bit old school. It's really easy to use from a physician standpoint, unlike Epic, which is painful for every single physician to touch, but yet it does a lot more for research and P4P and all the other things that we're going to be looking at in the future. Unfortunately, that's probably the model that our group's going to be going to, but for better, for worse, allows us to make some adjustments for more people at home and looking at our research and our pay for performance. And so, yeah, it definitely forced us to be much more diligent. I think from my standpoint, our website, I'm on the marketing committee as well. I'm the chair of the marketing committee. And so we said, look, this website needs to be clean. We've got time now. Let's make sure that everything is up to date. We've done a lot of good work with that. Obviously, most websites are changing as COVID has. That's just the standard stuff. But just looking at ways to enhance your websites, your marketing strategies should have changed during this time frame as well. And certainly then telemedicine became a huge component of that. And then online bookings. People are home, they're sitting around, they want to read good information. So your website needs to be really good. And then number two, you need to have an online booking platform that needs to be good. And that's always been a challenge because there's online booking platforms that just flat out stink. And we've probably all been there. So we're making those adjustments with our practice.
Dr. Tepper, when you decide on a new technology, what's the decision-making process within the group?
In a recent McKinsey study, 76% of patients preferred to use telehealth moving forward, and 74% were highly satisfied with telehealth. Telehealth is here to stay, and since 2016, Ortho Live has helped more than 1,000 orthopedic providers treat more than 500,000 patients. Our 100% HIPAA-compliant platform delivers one-click connect telemedicine appointment functionality via an app or a web browser. And our live US-based support team is here to help practices, providers, and patients connect and complete those visits. To find out just how quickly Ortho Live can turn your challenges into solutions while improving the patient experience, visit ortholive.com to schedule your demo today. Ortho Live, the world's leading orthopedic-specific telemedicine platform.
In our group, I get to explore and bring ideas and bring options in front, and we look at it. We do side-by-side testing, and I think the biggest rate-limiting reagent for these changes is the EMR, EHR, and a system. And it's super hard and very costly to change that. So you need to look at the best, most functional, most integrative platforms out there that work well with your specific EMR. And I think that with time, of course, as Adam says, like focusing on marketing, on better positioning in general. I mean, I was going to say integrating trainers and other, physical therapists in the community and making them a part of the platform can help. But obviously, if there's no high school and other sports going on around you, I feel your pain, man. And it's going to take a little bit of time to come out of it. But we need to integrate features and systems that also expand our offerings, expand our revenue basis. Personally, I think that it's time that physicians in general integrate in a big way preventive care, nutritional care, etc., to not just operate and treat the broken parts, but to control the obesity that we're challenged with, and to do more to sort of prehab people to get them in better shape. And I think through remote interactions and remote monitoring, I think we stand a chance. And there's enormous amount of innovation in that right now that is worth integrating.
Thank you. So Jeff, kind of as the referee, in running the practice, I'm sure you must get great ideas from all of your physicians.
Mhm.
How do you as a practice go about making those decisions?
We have a fairly decent structure here where we have an executive committee, which is a couple of the physicians who make those decisions. And then actually physicians do a kind of a term on there and they rotate around. So it's everyone knows who's on the executive committee and that's who's usually clued in on our decision making. But to the point, the one thing that we always look for now is just reporting. We have a couple of systems that we can't get very many good reports out of, and it makes tracking staff, tracking productivity challenging. So anytime we're looking at something that has to have good reports that can come out of it.
Got it.
Right. If you can't measure it, you can't manage it very well, right? Yeah, that's a good transition. I'm thinking about switching gears for a moment. Let's talk about how this is affecting the patient. What's been the feedback? What have you guys noticed through this, last 8-10 week journey on where, how this move and shift has impacted the patients?
So I think one thing and everyone understands this about telemedicine, but at my practice, we have a history, and it's not quite the reality anymore, but we have a long history of having really long wait times in the waiting room and then in the exam room. So that's kind of a community known thing that we're trying to turn around. But telemedicine has flipped that on its head immediately. So prior to, we might have a patient that got an injection and they may have their recheck appointment. They'd have to take a half day off work to come in and check in for their appointment, wait in the waiting room for maybe 30, 45 minutes, go back to the exam room, wait back there for a while, see the provider for 5 minutes, and then out the door. Now they can do that 10, 15-minute appointment on their break at work, in their car, or wherever they would like to be. And that has just been the biggest thing of, we've kind of had this reputation, we have to wait a long time, and now it's the exact opposite with, and not only that, but providers are more on time when they have their half-day telemedicine blocks because they know that patient's sitting in that virtual waiting room. And for some reason, that just gives the staff and providers a little bit more angst behind them of, they were sitting in a physical exam room before, but now they're just with their iPhone, but we feel like we need to get to them sooner. So that's been good. Yeah, and patients, while in Michigan, I feel like, or at least here, we've had most of our patients who are over it and they want to be seen. We still do have patients that are uncomfortable coming to the practice, or as mentioned earlier, they want their family members on there, or they want their nurse care managers on there. And so telemedicine has been a way that's made that a lot more seamless. And then the third part that I think is great is the continuity of the staff. So, they have the same medical assistant or nurse every time they come into the practice. And then when they're waiting for their telemedicine appointment, up pops that same medical assistant or same nurse that they're familiar with. And so having that embedded within the practice and that familiarity and continuity of the staff, I think is also key. And we've heard comments from patients that they really appreciate that too. Because you can get a primary care visit from health systems or other companies, but you don't know who you're talking to. You've never seen these providers before. So the fact that they can have these visits with their known providers also has been a big win.
Interesting. Have you noticed, have you seen any trend in terms of, online reviews or an improvement of your reputation score as a result of any of this?
So those are pretty, unfortunately, delayed as we get those. So we've definitely been looking for them. We're still kind of getting the comments of, I've been rescheduled 5 times and I'm sick of this. So hopefully next month in our some of our satisfaction surveys, we do hope to see that kind of shine through. There's been a couple, but to our practice, it's still so fresh and new when we implemented this that we hasn't been directly through there yet.
Dr. Metzler, you mentioned that you haven't had any patients complain. Have you had what's been the feedback directly from the patients?
Well, certainly at the height of the pandemic, I think it was pretty interesting that patients loved it. It could be at any level. New patients from the ER, they would just call. We'd set up a new visit form. X-rays would be sent over from the hospital via some platforms, different platforms we have to integrate the systems, to integrate the imaging, that is. And so that was pretty straightforward. There's certainly a little bit more uncomfortable feeling as a physician when you're evaluating a new patient visit over telemedicine. I think it takes some getting used to and some adjustments on how to actually accomplish that goal. Who's going to hold the camera? Are they going to flip the camera in reverse? All those kind of things that we haven't even talked about here. How do you get a good exam telemedicine? I think is really important from a medical legal standpoint and your comfort as a physician, particularly getting through those tons of, all the knee scopes and all the arthroscopy cases that needed to be seen in their post-op setting, but their global period, I mean, there was a lot of patients that just, it was easy to examine those patients at 2 or 3 months, 4 months, even 6 months out from a rotator cuff. You could have them do their exam, and they had no problems with it whatsoever. And as you got more comfortable as a physician utilizing that tool, then the patients seemed to be more comfortable with utilizing it too. And your documentation had obviously reflects that. So I think the easiest thing I found to integrate now into practice is back in Cincinnati. I mean, patients are certainly more comfortable now and in this region that they want to get out, they want to go to the grocery store, they want to try to shop, they want to go to their physician, and it's an opportunity just to get out of the house, honestly. And so these patients are willing to come in. Very few people are reluctant to truly come in, but it's enough to fill, even in my practice, 5 to 10 virtual visits Monday, Wednesdays, and Fridays, So I think that one of the challenges is, as you just mentioned, Jeff, is that you got your position is half days. We set it up however you want to run it, but we integrate ours within our practice. So I may see 2 or 3 patients and have a virtual setup and mixed in between there. What I found is interesting is now that I'm running my schedule, if I'm running a little behind on my telemedicine visits, patients actually complain. They say, well, why aren't you on time? Okay, but even though I may have made them wait 30 minutes 2 months ago in my office, they're actually expected to need to be on time for that virtual visit. And I've had a little bit of struggle with that. Thankfully, the Apple Watch works really well because it dings 15 minutes before their visit and then right at the time of their visit, which is certainly helpful to keep me focused on that. But it's something else dinging that we don't need dinging, like an old pager. But at the height of the pandemic, I couldn't even have it on because I would be doing 30 plus telemedicine visits in a day. And my nurse practitioner PA would be seeing my live patients in person, and I would kind of wave at them, and we had a good relationship to be able to do that. But that was kind of at the peak where we were still seeing 45 patients in a regular office day, with 30 of those being virtual and 15 in person. It was pretty crazy. Now we're back to close to 45 to 50 in office, and again 5 to 10 patients virtually a day.
It's interesting.
Yeah, go ahead.
Interesting when you point out the difference in time and the expectations. Mm-hmm. What's really, to me, striking is that your partner, Dr. Greiwe, who's had a lot of experience having started Ortho Live, when he compared 1 year to the next, he was able to do 213 more virtual patient appointments, which generated, not only did it save him on average, a lot of time, because the patient, when you looked at the patient's average visit virtually was 17 minutes. The average visit from door to door, when the patient would leave to get to the office, find the office, get seen, come back from the office, was a little over 2 hours. So you start comparing for the patient, 17 minutes versus 2 hours. Pretty striking difference.
I think that's where it becomes challenging too. As a physician, we're used to, for a standard meniscus debridement post-op, I mean, we're probably in the room 3 to 4 minutes as a physician if you look at the actual numbers, maybe 5 if you're lucky. But then you can get stuck on telemedicine and you can be on the virtual visit for over 10 minutes. And I think productivity comes into play too. Is how productive is a post-operative visit? Even though it's convenient for the patient, is it really convenient for the physician? Or do you set aside time to do post-op checks at your lunchtime while you kind of munch away a little bit? That's the hard part, I think, of telemedicine. I think that we're all trying to figure out the most efficient way to see our patients via telemedicine that provides the best patient experience and the most revenue for our practice. And I would love to see that written down somewhere, because I've yet to see that anywhere. Because if we can figure that one out, then we'll be much better off. Because maybe Jeff's practice is right. Maybe I should set aside and not do any telemedicine Monday, Wednesdays, and Fridays, except for my Wednesday afternoon. I should have 20 virtual visits only. And I don't know if that's the right way. And I've yet to see a practice show me which way is better. But I'd love to know.
Dr. Metzler, you do a great job of teeing these questions. It's like you knew what was coming.
This is last minute. I got the email at 3 a.m. last night.
So, Dr. Tepper, I think we've answered the question that we see telehealth becoming a longer-term strategy. But the bigger question is, how do we leverage it for greater revenue?
Well, first of all, for spine surgery, I just want to sort of chime in that, in spine surgery, the biggest challenge is really patient selection and really exhausting conservative care and sort of using a lot of options before we go to the knife. I think like Adam says, you know, in sports, et cetera, a lot of times it's the MRI and the mechanical symptoms and a fix and a happy patient at the end. Logistics right now of transitioning the practice to this method or that method is painful, period. We're going to walk through. But, you know, for spine surgery, there's been a study done out of Jefferson, the Vaccaro group, specifically, that looked at the small group for outcomes based on surgical outcomes for comparing patients that had virtual physical exams and those that had in-person physical exams. There was no difference. In spine surgery, short of the emergency involvement, which we're still doing, for elective spine surgery, a lot can be done virtually. And there's a lot of patients with emotional issues and other issues that you really need to work through to get a good result. And I think that integrating some of these things into the practice, some other allied health professionals within the practice that can offload the physician when things get too time consuming or additional hand holding is necessary. At least we have the option to set up another appointment with the pain guy in the clinic or with the LV with the RN, et cetera, to keep the patient feeling well managed, to keep conservative methods done, and to interact with the patient to their satisfaction. So, I mean, in general, I think that remote patient monitoring is going to, you know, and wearables are going to increase over time. And I think it's worth looking into now to try to find strategies and methods, especially now that we're in a transitional period where I believe that payment pairing is still in effect and some of the restrictions are still somewhat relaxed. I think a lot of it is going to change. And honestly, I don't know which direction is going to change, but I know that in LA, with the way the traffic is and the way that long waits are, et cetera, patients really prefer and take on the telemedicine visits. They're appreciative. They obviously, there's lots and lots of visits that can be done well on the, you know, without face-to-face value. And some of it, Adam, has to be like, what do you see yourself doing? How do you want to condition your followers, your group of patients, to believe that you will give them the best care possible, the most efficient and the best outcome? And part of it is going to have to be you carving your own way and say, this is the way I do things. And I believe, like in LA and other places, you know, we're going to get into, now it's the surge and next is the flu season. This is going to go on for a while. And the more we increase our productivity, efficiencies, integration, adding methods for easier prescription and you know, integration with the physical therapists and renewing prescriptions and so on and so forth. The more we can do that online, the more efficient we can be, and I think that ultimately we can grow the revenue as well.
Dr. Tepper, I think in that same article you quoted Dr. Vaccaro, he mentioned that he felt he could effectively see about 80% of his patient population via telehealth.
You know, as I said earlier, I think it really is very subspecialty dependent. It's pretty much specialty dependent. I think that some of our colleagues that are neurologists that are doing a headache, and you know, they can really do a lot by reviewing diagnostic studies and telemedicine visits. And I think some of these primary care and specialty care clinicians are going to do 80+% of their work telemedically and 20% or so in person. For the surgical intensive specialties like sports, et cetera, you know, ultimately I think it's going to be whatever the clinician wants based on the community that is in, based on the type of patients that he gets, whether they're, I mean, the elderly is struggling with adoption new technologies. And like Adam said, like just the logistics of getting it done is difficult. So if your demographics shifted, you're going to experience some secondary effects from that. It's going to be more frustrating. We're also working on systems that are much more octogenarian friendly right now. So ultimately that's going to change as well. But it's going to settle down at a very specialty clinician and environment specific rate, which I believe is going to be substantially higher than it is today.
So Jeff, for you, as you look at the practice as a whole and incorporating all of your surgeons, one of the people watching had a question that said, do you plan to integrate or have any desire to integrate a system to offer, track and monitor patients' joint health, activities and controlled exercises? And this would be an opportunity to increase revenue.
So I can't say that we've looked into that specific example, but we are looking at every time a new enhancement comes out through OrthoLive or whatever, any of our systems, how we can help implement that. So even recently having where we haven't done it yet, but the medical assistants being able to have their time with the patients as well through OrthoLive. And I think this is a new growing business, I think, as we all know, and anytime something changes, we want to act on it and jump on it. And again, because we're only 2 or 3 months in post-pandemic, we haven't had time to really go and enhance our system yet. We've got it installed quickly. We've been able to use it, which has been great. And now we're getting back to normal, and so the newest normal. And so a lot of our energy has been focused on that. And I think once we get past that a little bit, then I'll be able to look, okay, we installed this 2 or 3 months ago when we were in middle of the pandemic. How are we using it correctly? Are we using it to its full potential? It met the need at the time, but what else can we do with it? So that's something we're absolutely going to look at. It's just time, bandwidth.
So Jeff, let me ask you a follow-up to that. When you're looking at your practice as a whole and you look at all of your surgeons, how do you encourage, so when you find a surgeon that's utilizing telehealth and they're doing a great job with it and they're increasing the revenue to the practice, how do you encourage the other surgeons to adopt that same technology and use it to a greater degree so that the entire practice is benefiting from the increase in revenue?
Yeah, so there are some, I would call maybe low-hanging fruit tactics, such as that we have had this, where some of our overachieving physicians have spoke at the board meeting on why they do it, what they hear from their patients and whatnot. I think the balance is to try to get some of their partners to come along. The balance is some of those partners who may not embrace it as much are saying, my patient satisfaction scores are still high, my patients are still coming and seeing me, I don't necessarily see a need. But kind of our on the horizon, what we're currently looking at is, well, how does it impact overhead? So while we still need staff to verify the insurance and whatnot, current state today, when a physician's in the practice, they usually have a little team around them of usually 2 medical assistants and a nurse. And with telehealth, though, if they have that afternoon, which they each have a little bit different schedule, but a handful of providers just do a half day of telehealth a week, they only have 1 medical assistant with them. So right there, and that's kind of, tugging on some different heartstrings. So it's not necessarily we want to use telehealth, but if you do use telehealth, the overhead for the practice will be less because we do need less staff for telehealth appointments. So we're just finding unique tactics like that to come at it from different angles.
Okay.
Jeff, just touching base real quick on earlier you mentioned, you have less furniture in the front because you can't have the seats so close. You've got space. I mean, how is this going to affect your commercial real estate? Do you still need such a big office? Do you need as many clinical rooms? Is that going to change? Is the equation changing as we start thinking how this practice is going to look?
So I think it's all about a balance. So obviously obtaining more real estate is an idea, but a long-term and also expensive idea when we can use things such as telehealth. And we are doing okay now with, even though we limit the patients, but having more unique process flows of, we know on Tuesdays and Thursdays we're really busy. We have a lot more physicians in the practice than we do have patients waiting in their cars from time to time. Really taking the strategic look at provider schedule. So prior to COVID, Fridays around all of our practices was a little bit lighter. And now we need to kind of look at, okay, we're putting some more providers on Fridays instead, just so we can have less patients in the practice at any given time. And all of our other ancillary departments really appreciate that too, because it was mentioned earlier, cleaning, which is great, and we all need to be doing this anyway. But when we started cleaning the x-ray equipment in between every patient, my x-ray techs were looking at me just sweating bullets, going, oh my gosh, this is like putting us behind. There's so much more to do. And then spreading the physicians out throughout the week and having some on Saturday, it helps the x-ray staff, helps our durable medical equipment staff. So that's a piece, kind of another lever we're trying to pull. Yeah, and it's just different every day, to be honest. It's surprising that we can still fit patients in the waiting room. I think back to the days prior to COVID, and it looked like a packed waiting room, and we took out the majority of the chairs, and somehow all the patients are still fitting. We do still have visitor restrictions, which is good and bad. We get some pushback. We got pushback, a lot of pushback, and we allowed no visitors, but we actually had an executive order from the governor to allow no visitors for a period of time. And so now I think that's helped us by saying only one person allowed for the appointment. And then we have had days where we have patients coming in, waiting room is full, looking full or unsafe for social distancing, and we ask the visitor just to wait in the car, and we'll call them in when it's time for the appointment. So honestly, every week still is a little bit different of what can we add to the equation as we get a little bit busier and busier. I don't think there's a great playbook or platform for how we're supposed to navigate through this unless someone had a huge practice they aren't currently using. But we're taking it day by day.
Interesting. Thank you. One last point or question, Dr. Tepper and Dr. Metzler. We were talking about the roles changing. Things are changing in the future. I think Vaccaro was quoted in Becker's recently saying that he envisions, more of his PAs and MAs doing some of the triage work. So he'll only see the patients that really are probably going to be, primary surgical candidates. That way, instead of him seeing 45, 50, 60 patients in a day, he may be able to focus in on the subset that are actually going to need the more complicated discussions. How do you think, are those roles clinically changing in your mind?
Insight Marketing Group is your practice's complete marketing solution. Since 2006, we've helped practices just like yours attract and retain patients through traditional and digital marketing, employee engagement programs, and strategic communications. Anyone can market your practice, but few can understand the dynamics behind decisions. We can do both while providing measurable results and noticeable improvements. For just one flat fee, you'll get everything you need to market your practice and improve your online reputation. And yep, that even includes a new website. At Insight Marketing Group, we simplify your marketing so you can run your practice. Check out pricing and learn more at insightmg.com today. That's Insight, M as in marketing, G as in group.com. You'll be glad you did.
For me, I've always had a kind of a practice that had elaborate use of allied health. Chiropractors in my office that were functioning as physician's assistants doing the non-operative care, and physician assistants, nurse assistants, and so on. I think that, again, in my specialty, a lot of it is complex decision-making, referrals for injections and so on and so forth, for conservative care, patient selection. And I think that the PA and the physician extenders that we train carefully as our extenders can really carry that message well and can really make it much more efficient and enable us to be more efficient with our time, our surgical time, and our family time, our time off. So, I'm optimistic that through working through this and integrating some more allied helpers can free us up, and we can find a way to have a better lifestyle ultimately and maintain the income.
The region sort of dictates that pretty significantly. I mean, I think some regions are accepting of extenders and other regions aren't. I mean, our region is fairly accepting of extenders, and there's other regions that don't accept that very well. I think, my personal opinion, particularly with telemedicine being new to our practice, was I took the onus of saying telemedicine is my baby, not my extender's baby. And I want to know what's going on. I'm very OCD, and I don't want the responsibility or liability to be on an extender not being able to visualize a patient appropriately or adequately over telemedicine. And I want the responsibility and the medical legal liability for that if something happens. But I don't necessarily want to, if you quote, babysit somebody over a telemedicine visit when I trust what he's clinically doing in the office already. So I took the onus and said, this is mine. You don't have to worry about telemedicine. And unless I tell you you're doing telemedicine, don't expect to do telemedicine ever. That's not what other people in my practice have done either. A lot of them have said, I want nothing to do, particularly the older physicians. I want nothing to do with this technology. This is crazy. Who would ever force me to do this bogus stuff? but my 30-year-old extender is going to be wonderful at it, aka forced to do it, and they probably never will integrate that. Now, I don't think us as a 30-person group, we're ever going to force someone to do telemedicine. That's just like forcing somebody to be on your board. That's not probably the best decision because they don't really want to participate. If somebody wants to be a part of something, then they should be. And if they don't need to be. But if the time comes where it's not producing and it's not effective for the group's overhead, which would probably be unlikely if they're already producing well before, and that might have a conversation be brought up. But I think the use of extenders, I don't think that role changes too much right now, except for how much you're willing and want them to be involved with telemedicine. Again, I've given you my approach. I've taken it. It's been successful for me. Besides Dr. Greiwe, I perform the second highest telemedicine group visits within our group. I'll continue to do that. I would not have done that, to be honest with you, if it wasn't for this pandemic. I did not see a value within it. I thought it would be a waste of time. And frankly, pre-COVID, it would have been hard to do. It would have been hard for me to integrate it in without taking time away from my family.
Right.
And
Right.
to me, that's the hard part with 3 children, is everything I view as family first, patient second, and in the operating room, patient first, family second. But, I want to be home with my family like anybody else does. And I want to be efficient and effective. I think generating more surgeries like any other surgeon, we want to be busy surgically. We want to be in the operating more, performing. But if you look at your numbers, it's absolutely amazing when you have a full office, how much revenue you generate from being an effective office provider. And so I think if you're very effective and efficient in the office and learn to see patients efficiently with your extender, then, you start looking at surgeons saying, well, I'm not here just to soak up all the surgeries from the group. I'm here to see a lot of patients for our practice and help triage to get the patient to the right place. And if I'm the right person, great. And if I'm not the right person, I've got plenty of other great physicians within my group. And for being on the sidelines 14 total years now, a lot of what we do as sports sidelines physician is triage to the hand guy, to the foot guy, to the coach's total joint, gets to my joint guy, so that's the way that your practice should continue to evolve. And we really shouldn't lose sight of that. Telemedicine shouldn't change that for us, and COVID shouldn't change that for us.
Thanks for listening to the Growing a Successful Orthopedic Practice podcast. Please consider pressing subscribe on your podcast player so you never miss a future episode. And if you haven't given us a rating or review on Apple Podcasts already, we ask that you take a spare minute to help us reach and share our medical